Greetings of the day, everyone, wherever you are. Welcome to GAPIO Radiology International Lecture Series. For those of you who are joining for the first time, I'm Dr. Vinita Sharan. I'm the CME advisor of radiology for GAPIO. At the start, I would like to inform the audience that we will have a question and answer segment at the end of the talk. So if you have any query, please put it in the chat box. They will be answered later. So the topic today is imaging in stroke, when normal CT may not actually be normal. And this is very important topic because stroke is third common cause of death and disability globally, with an incidence of 11.9 million annually. And India records 1.8 million new cases every year. Timing is a critical component in the diagnosis and initiation of treatment of stroke. Medicine relies heavily on imaging, both CT scan and MRI, for early diagnosis. So we have our speaker, Dr. Shailesh Gaikwad, who is an authority in this field. Our chairperson is Dr. Bindu Menon. She will add her insights in such diagnosis. And our moderator for this evening is Dr. Arvind Chaturvedi. Dr. Chaturvedi is Chair Emeritus of Radiology and Interventional Oncology Governing Council. He is former medical director of Rajiv Gandhi Cancer Institute and Research Center, New Delhi. He is founder president of Society of Oncology in Imaging, India. He has a lot of interest in medical education and academics. He has presented his research in many national and international conferences. He has numerous publications in his name, and he has received Lifetime Achievement Award in Oncology by Biobank Foundation India in 2025, by IRIA Delhi in 2024, and by Oncology Forum in 2023. So I invite Dr. Chaturvedi to moderate the session and also introduce and invite our chairperson after that. Thank you, Dr. Chaturvedi.
Thank you very much, Dr. Vinita, for that very kind introduction. I'm glad to be here and moderating this particular session. I feel honored. GAPIO, which is Global Association of Physicians of Indian Origin, is a worldwide organization, and it runs across 57 countries. I think there are 1.4 million Indian physicians of Indian origin who are spread all over the world. And the mission is to improve health worldwide. And to meet that objective, GAPIO conducts these CMEs on a very regular basis. I think it's on a weekly basis. And of late, since 2022, I think they've started doing the CMEs in radiology also. And as was mentioned by Dr. Vinita, the topic today is imaging in stroke when normal CT is not normal. And this is such a wonderful topic. We know that the incidence of stroke is rising, and it's very critical to diagnose it very early so that early treatment is started, and very often the disability can be salvaged or the problem can be controlled. And there are various methods to do it. It can be either intravascular thrombolysis or it can be endovascular thrombectomy. But the key is speed in diagnosis and in the intervention. And to chair the session, we have a very eminent neurologist, Dr. Bindu Menon. Dr. Bindu Menon is here to chair the session today, and we'll be enlightened by her expertise in the field, and she'll be interacting after the talk is over, maybe with Dr. Gaikwad and maybe with the audience if there are questions, and of course I'll be a part of it. Professor Bindu Menon is the head of the department at Apollo Hospitals, Nellore, India, and founder of Dr. Bindu Menon Foundation. She has a teaching experience of 24 years and over 100 publications. She is the editor of 5 books and has 22 chapters to her credit. She has 9 fellowships to her credit and has delivered 12 oration lectures. She has led extensive community outreach initiatives through her foundation, conducting over 270 free medical camps, more than 260 public awareness programs across urban and rural India. Her flagship initiative has been Neurology on Wheels, along with tele awareness program. Apps like Stroke Help, Epilepsy Help, NeuroCare, and Stroke Connect have significantly contributed to reducing the treatment gap in neurological disorders. She is the founder of the startup Artificial Intelligence in Neurology. Dr. Bindu Menon, the chair of who's chairing the session today, I request you to please introduce Dr. Gaikwad and proceed with the session.
Thank you very much, Dr. Arvind, for this kind introduction. It's my pleasure to welcome everyone to today's webinar on imaging in stroke when normal CT is not normal. As rightly pointed out, stroke is a true medical emergency and where every minute counts. And we often say time is brain, but equally important is the principle that the right image at the right time saves the brain. Now, let us just imagine a patient with sudden hemiplegia arriving within an hour of symptom onset, and we get a CT scan. It is reported as normal. It's extremely difficult in the emergency department whether we should reassure the family and wait, or do we recognize that this is normal scan can actually represent a race against time. And today's webinar is about exactly that challenge, understanding what a normal CT is and when it is not abnormal. The challenge is to knowing what to look for and what are the subtle early ischemic event changes that we can see, understanding the limitations that the CT can have, especially in the brainstem stroke, deciding when we should go for an advanced imaging as well. Today's webinar is going to focus on these critical aspects, and we are extremely fortunate to have an outstanding expert with us today whose experience in stroke imaging and acute stroke management is going to help us navigate these important concepts through real-world examples and evidence-based practice. My pleasure to introduce formally Dr. Shailesh Gaikwad. He is the professor and head Department of Neuroimaging and Interventional Neuroradiology and Chief Neurosciences Center at All India Institute of Medical Sciences, New Delhi. He has 155 publications. He has co-edited 3 books, 27 book chapters, citable abstracts 200, 1,004 citation, and impact factor of 169. He has set up the MRI services at AIMS in 1993. He's a founder member of epilepsy surgery team in April 1995. He set up the carotid stenting and acute stroke intervention therapy in 2000. His social impacts are PMJ Ayushman Bharat, Government of India, for recommending a comprehensive package in interventional neuroradiology procedures, National Stroke Registry ICMR, Government of India, for recommending standard reporting of neuroimaging and standard of care across districts and higher hospital-based services, domain expert on DNBE for proposing the fellowship program, and course curriculum for training specialists and helping the capacity building of the trained workforce. With that, it's my pleasure to welcome our esteemed speaker. We look for his wealth of knowledge and for an enlightening and interactive session. And I encourage everyone to actively participate in the discussion and kindly put your questions in the chat box, which would be addressed at the end of the session. Thank you very much. Over to you, Professor Gaikwad.
Thank you, Dr. Bindu, for that very generous introduction. And I'm really honored to be the guest speaker for today's session. And my all thanks to Dr. Vinita Sharan, Dr. Arvind Chaturvedi, and everybody else who has made this possible. And today I'm going to speak on imaging in stroke when normal brain CT is actually not normal and what needs to be done in order to identify the stroke. As rightly said, that stroke outcome depends upon the time of intervention, be it IV thrombolysis or mechanical thrombectomy. So it is on the part of the neurologist and the neuroradiologist who are actively participating in the acute setting to diagnose and manage it appropriately. So coming to the main topic, so I think let me begin my talk by defining what is a stroke. Stroke is defined as a neurological dysfunction caused by focal, cerebral, spinal, retinal infarction, or a hemorrhage. And in order to emphasize its importance as equivalent to the brain, the heart attack, it has been labeled as brain attack. So this was coined by American Stroke Association. And then we know what is the diagnosis called as transient ischemic attack. When the deficit lasts less than 24 hours, it is called TIA. But what is the importance of TIA? It means that nearly 1 in 5 people who have suspected TIA will have a stroke within the next 90 days, and 2 in 5 if they are subjected to imaging. The CT scan or the brain MR will show presence of infarct. So actually, it may not be a TIA, it will be a stroke. But because the clinical diagnosis based on the reversibility of the deficit, we call it a TIA. Now, the National Institute for Neurological Diseases and Stroke, that is a NINS trial in 1995, showed the benefit of IV thrombolysis when it is instituted within the first 4.5 hours from the onset of the stroke. The concept of salvageable brain tissue, penumbra, came later on, especially when we realized that the patient who come beyond the therapeutic window actually may be suitable for mechanical thrombectomy if there is something called a salvageable tissue. Hence, the other concept of imaging for perfusion came into existence. Now, in order to make this globally aware, the WHO coined a term called FAST, where the F stands for weakness in the arm, face, speech, and the last word, the time. Actually, it means that you have to rush, call the 999 and make the patient rush to the hospital. So act fast is the word which is commonly popularized. But later on, the limitations were known with this mnemonic, the FAST, because it excluded all the stroke which happened to be in the posterior circulation. And they commonly present with balance in difficulty, that is the incoordination or imbalance. And sometimes the stroke may be in the eye, like the posterior cerebral artery infarction, or in the retina. So another word, BFAST, was coined in order to include the stroke in a comprehensive manner. So the global burden has been rightly said that it's about 12.2 million new strokes happens each year. And 1 in 4 over 25 years have a stroke in their lifetime. And 6.5 million annual deaths happen because of this stroke. But importantly, it is a leading cause of disability worldwide. Out of this, the metabolic causes constitute about 71%, the behavioral factors like the smoking, the poor diet, low physical activity account for 47%. But the most important is the high systolic blood pressure, which is the largest single risk factor for stroke. Now, coming to the burden perspective in India, stroke is the leading 4th cause of death. And in fact, is the 5th leading cause of disability. The incidence has been studied from a study conducted between 1990 and 2016, where it said that the incidence may range from 96 to 187 per lakh population. However, there is a variation in the urban and the rural prevalence rate, where the rural prevalence is a little more than the urban prevalence rate. 50% increase in incidence of heart disease and stroke happened between 1990 and 2016. And what is important from Indian perspective, that 11% of the stroke may happen in patients aged between 18 and 44 years. However, 89% happens in patients who are over and above 45 years of age. But essentially what it means, if you compare the age of onset of stroke, in a Western population, India, at least 10 years younger patients have the stroke in their lifetime. So this is the most important thing. And what is so important, that the stroke can be classified broadly into 2 groups. The ischemic, which constitute about 85%, and they are amenable for thrombolysis. But if the stroke is hemorrhagic, which is fortunately only 15%, then IV thrombolysis or mechanical thrombectomy is not required. Intracranial hemorrhage of this hemorrhagic 15% may be caused by about 88%, and subarachnoid hemorrhage is about 7%, where the cause could be aneurysm rupture. Now, coming to the etiology of the ischemic stroke, it is coined as a mnemonic ASCO classification, where A stands for atherosclerosis, which is the most common cause. The common sites for atherosclerotic disease are the carotid bifurcation, the intracavernous segment of the carotid, and the mechanism could be the complicated plaque, rupture, thrombus, and embolism in the distal circulation. The small vessel disease, the commonest cause is diabetes mellitus, and small vessel disease will attribute to a small lacunar infarct, which by definition is less than 15 millimeter. The commonest sites are the basal ganglia, the thalamus, the deep white matter, internal capsule, and pons, and sometimes subcortical white matter. Cardioembolic, the commonest risk factors are the myocardial infarction, arrhythmia, valvular heart disease, most common cause in young patients. And of course, there are other miscellaneous causes, and the diagnosis sometimes may be difficult to know the etiological diagnosis. So we call it I think hidden or a cryptic form of stroke. Now, in children, the cause of the stroke may be entirely different. The commonest cause in Indian setting is the congenital heart disease, which is often a cause of the cerebral thromboembolism, including the myocardic aneurysm. Then trauma may cause dissection. Sometimes the dissection may be spontaneous. Infection like tonsillitis, abscess, meningitis, they can also cause stroke by invading directly the blood vessels. And we know from our experience during the COVID time that the mucormycosis or the fungal was the commonest cause of invading the blood vessel and causing complete infarction in the distal circulation. Drug abuse are again another very important risk factor, blood dyscrasia, and there are other syndromes like Marfan syndrome. In India, fortunately, we see a lot of cases of Moya disease, but they are getting treated with anastomotic surgery, and it entirely goes into the surgical domain. So this is one example where a brain MRI, including a diffusion-weighted image, shows the restriction, and clearly it can be identified from the stroke. This is an example of an abscess. Now, staging of the stroke is based on the day. So whether it's a hyperacute when it's less than 12 hours, it is acute when it is 12 to 24 hours. When it is subacute, it's more than 2 days to 2 weeks. And chronic, when we say it's more than 2 weeks to 2 months, that is the 8 months is a chronic stage and beyond. And what is the importance that after 8 weeks, the infarct may not enhance at all. So that's why the timing of the infarct is very important. Coming to the pathophysiology, you know very well what happens in the autoregulation. Failure happens when the major vessels leads to occlusion. There is maintenance of the cerebral blood flow in the cerebral perfusion pressure range of 150 to 150 millimeter of mercury. As there is reduction in the cerebral blood pressure, less than 55 millimeter of mercury, it leads to reduction of the cerebral blood flow. So this is just a diagrammatic showing the autoregulation, how the normal blood pressure drops and leads to these are the cascading events which follows when the ischemic stroke happens. So the immediate effect is the decrease in the cerebral perfusion pressure, which further reduces the vascular resistance and the causing the vasodilatation. As the vasodilatation has happened, marginally there might be increase in the cerebral blood volume, but later on it results in the increased extraction of the oxygen in order to maintain the perfusion. And then in the end, we come to the phenomena called a penumbra, which is a salvageable tissue. If there is further fall in cerebral perfusion pressure, the maximum oxygen extraction is reached. This will finally cause reduction in the cerebral blood volume, which will be attributed by the reduction in the oxygen consumption. And this will eventually lead to the irreversible damage, which is eventually called a core. So core is an irreversibly damaged tissue in the brain, resulting in the antegrade flow of the artery. Showing a schematic, the central part is the core, which is irreversibly damaged brain, and the surrounding area constitutes the penumbra, which is generally maintained by the collateral circulation. So ischemia, we have a central core, which is an infarcted area. It is a irreversibly damaged brain tissue. The penumbra is generally a peripheral part, which is representing the stunned ischemic parenchyma that has ceased to function. And most important thing is that it is potentially salvageable if proper treatment is offered to the patient. So this is another schematic. The infarct core happens when the cerebral blood volume is less than 10 ml per 100 gram per minute. Ischemic core ranges between 10 and 22. Oligemia is 22-60. And the normal brain gets the 60 to 100 ml per 100 gram per minute of the blood. This is another schematic. We show the core, the neurotransmitter zone, the penumbra zone, and the oligemia zone. So symptomatically, I think the core is the symptomatic area. Penumbra at times may not be symptomatic. Now, coming to the main topic of the talk today, the role of imaging in acute stroke. It is easier to remember by remembering the 4 Ps. What are the 4 Ps? The 4 Ps, the first P stands for parenchyma. We want to image the parenchyma so that we want to know whether it's an intracranial hemorrhage or it is caused by an ischemic stroke. The other goal is to know the early signs of ischemic stroke so that we can diagnose it correctly, even if the findings are very subtle, very nominal. The second P stands for pipes, which are the blood vessels. The idea is to assess the intracranial as well as extracranial circulation beginning from the carotid to vertebral arteries to know the location of the thrombus. And perfusion, of course, is to know the various perfusion parameters, that is CBV, CBF, mean transit time, time to peak. And finally, coming to the penumbra, which assesses the presence and extent of the penumbra, which is generally maintained by the collaterals. It is also important to know while we are imaging for a stroke, we don't have to spend too much time on imaging because as the delay happens, each neuron may continue to die till reperfusion happens. And therefore, we have to balance our act between time versus information. So going back, again, moving on to the modalities. What are the modalities? We have on one hand computed tomography, on the other hand, magnetic resonance imaging. By and large, CT is the first line imaging tool due to its widespread availability. Second, it can appropriately rule out the intracranial hemorrhages. Now, magnetic resonance imaging is highly sensitive for detection of early ischemic insult, particularly if CT findings are normal, even when the clinical suspicion is pretty high. Then we come to the parenchyma. The parenchyma can be imaged both by CT and conventional MR. For the vessels, we have 2 modalities again, CT angiography as well as MR angiography. For functional imaging, again, we have 2 imaging modalities, the CT perfusion and the MR perfusion. Now, detection of the cerebral ischemia, if you look at the CT, traditionally, it is used most commonly because of the speed of acquisition of the data, and it is widespread in availability. However, if you look at the MR, when the CT is normal, the single most imaging sequence that is highly sensitive at the same time is highly specific is the DWI, diffusion weighted imaging. The CT's angiography source images should always be looked at, especially when the normal NCCT is normal. The CT source images will show paucity of the blood vessels in the infarcted zone, which may be failed to be detected by NCCT. And at times, it may approach the sensitivity of the DWI, especially when the ischemia is large in size. However, it is less effective when the infarct size is very small, especially in the brainstem, and the infarct is located in the posterior circulation because of the beam hardening effect of the dense bones that surround the brain. So if you look at the suitability and the sensitivity, I think the DWI is the most sensitive, followed by CT angiogram, source images, and comes the third number, the CT scan. So what are the early findings in CT? That's very important. Now, the early signs of infarctions. First thing is to rule out hemorrhage, which is an absolute contraindication for IV thrombolysis. Now come to the signs of early infarct, which are positive in almost 50% of the cases. And if one is not well aware of these findings, we can easily diagnose this as a normal case. The first most important thing is, especially when the middle cerebral artery is occluded, Look at the basal ganglia, the sign we call it an obscuration of the lentiform nucleus sign. Come to the loss of gray-white matter distinction sign, we call it a loss of insular ribbon sign when it is present in the insula. Then the sulcal effacement, the hyperdense vessel sign, which is highly specific, but unfortunately present in only 30% of the time. Then the next role of CT scan is to know the extent of the infarct, the mass effect, the impending herniation, and so many other things. And of course, we have to rule out these stroke mimics. Now, this is an example of intracranial hemorrhage in a patient who was hypertensive. The hemorrhage is in the gangliocapsular region. So this means that this is a contraindication for IV thrombolysis. The another example of a right MCA fully formed infarct, you can identify from the shape, the location, and the sharp interface between the infarct zone and the normal vein parenchyma. And of course, this is a finding of a right MCA territory infarct. Then signs of early going again. Now, this is another example. Look at the normal basal ganglia on the right side, the caudate, and the other structure. But if you look at the left side, the involved side, look at this basal ganglia. It's clearly hypodensity in the basal ganglia. We call it a loss of obscuration sign. There is loss of delineation of the basal ganglia, which is secondary to the hypotension and blurring of the gray-white matter interface. Another example, this is a loss of the insular ribbon side. Now compared to the right side, the insula of the right side is normal, the basal ganglia on the right side is normal. But if you look at the left side, look at the insula here, compare it to the normal side. There's obviously obscuration of the insula, and we call it loss of insular ribbon side, which is attributed to the loss of definition of the gray-white matter junction in lateral margin of insular cortex. It is more susceptible to ischemia following the MCA occlusion than portions of the MCA due to poor collateral supply. Coming to the next sign, we call it a hyperdense MCA sign, especially when we see the hyperdensity or the thrombus in the middle cerebral artery. And it is highly specific, almost by 95%, but the sensitivity is about 52%, and the threshold, if it is higher, generally it is more specific. Now, what are the pitfalls? Hyperdense vessels can also be seen with polycythemia or when there is a calcification in the middle cerebral artery, which is usually bilateral. So you have to be pretty careful. So just don't look at the middle cell, the M1 segment. Go beyond that into the M2 segment. Sometimes you may get a clot in the M2 segment. We call it a MEVO occlusion. So this is another important thing, and we should be pretty clear. Sometimes the patient may come with the feature suggestive of posterior circulation. There the CT scan may be normal, but you should always focus on the hyperdensity in the basilar artery, which when picked up is highly sensitive for suggesting that the thrombus is in the basal artery. Moving on, these are some false positive hyperdense middle cerebral artery. There's a lot of, I think, articles which can be read on the literature. But coming to the next concept, sometimes when the CT looks relatively normal, there is an importance of making the window level, center level changes. Now, this looks pretty normal to a person who is not really trained. But if you make the changes in the center level to 32 and change the window depth, here you can see if you compare with this area on the left side, there is area of hypodensity in the basal ganglia. And sensitivity raises to 70% from 40 to 50% just by changing the window level and not doing much on it. So this is the importance of changing the window level. Then what are these signs of fully established infarcts? And what are the consequences of an infarct which is expanding? I'm going to just talk about that. So this is a large infarct, and you can see that there is a shift of the centrum, fully infarcted zone. The entire territory of the middle cerebral artery is gone. Now there is a shift of the midline to the other side. And the secondary vascular injuries in the form of PCA territory, the brainstem infarction, the Durett's hemorrhage may set in if the patient is not offered the choice of a decompressive splenectomy. So that's why I think it's important to know the complication of the stroke by repeating the CT scan after 24 hours. Sometimes we do repeat after 48, 72 hours. based on the treatment that is being recommended. Now, coming to the other concept, which is aspect score. What is aspect? Basically, this has been proposed by the Alberta, which is a CT scoring system where the images are taken at two levels, at the ganglionic level and at the body of the lateral ventricle. The total region of the anti-circulation, particularly the middle cerebral artery, is divided into 10 zones that include the caudate, the lentiform nucleus, the internal capsule, the insula. Then at the level of the capsule ganglionic area, we have M1 frontal, the M2 in the temporal lobe, and the parieto-occipital lobe, the M3 region. At the level of the lateral ventricle, we have M4, M5, and M6. So these are the 6 and 4 level at the level of the basal ganglia, that is total 10. Now, based on each region affected, you have to subtract from the total score of 10 to get the exact aspect score. So this is the CT scan at the level of the basal ganglia. And this is the CT scan at the level of the body of the lateral ventricle. So these two regions must be focused on in order to know the aspect scoring. Now, coming to the software that can be used to know the aspect scoring by automated version of Rapid AI, I think this can be installed on your system. It's a third-party purchase. It will at least save your time from eyeballing and visual region. So these are some examples where the stroke is in the left side cerebral artery, and this aspect scoring is done by using a Rapid AI. But we can also do by eyeballing, visual observation. So this is an example where there's an infarct in the M5 region and in the insula and in the M2 region. So the yellow regions are the infarcted zone, the blue are the normal area. So if you minus these 3, the aspect score here is 3. Now, what is the importance of aspect scoring system? If the aspect score is more than 6, 7, 8, 9, and sometimes 10, even if there is an occlusion, if you intervene, the outcome is fairly good. But if the aspect score is less than 6, less than 5, then the functional outcome is usually pretty poor at the end of 3 months. And if you intervene, there are more chances of symptomatic hemorrhage. And this is a relative contraindication for mechanical thrombectomy. However, this is an old data. We have now trials on low aspect from 1 to 3, from 3 to 5, and 6 and above. And some data are showing that even in an aspect score of 3 to 5, some benefit can always be offered to the patient. So moving on, what is the advantage of CT versus diffusion-weighted aspect scoring? DWI aspect value is lower, means that the DWI is more sensitive to ischemic changes. However, CT visualizes density change and swelling. So we are doing an indirect visualization by looking at the density changes in the adjacent brain parenchyma and the white matter. DWI visualizes the signal change. So signal is usually much easier to appreciate to the naked eye. However, we should not be over-reliant on DWI, and sometimes we can miss the opportunity to thrombolize the patient. Among patients with moderate to severe acute ischemic stroke, the ability of CT to detect signs of early cerebral infarction is comparable with DWI. So if there is a total points of 10, score less than 7 is suggestive of a poor functional outcome. Coming to the aspect scoring for poor circulation, posterior circulation stroke, a similar score is also developed for assessment of extent of posterior circulation stroke. So each side of the cerebellum, each side of the occipital lobe, and each side of the thalamus is given 1 point each, while 2 points are given when the stroke is in the midbrain or in the pons. So total points is 10. In this posterior circulation, anything below 7 aspect score has a poor functional outcome. Now, this is the midbrain, and this is the pons and the cerebellum on the left side. So total score is 10. Now, role of CCT, if you look at it, for parenchymal imaging, CCT is not required. But if you inadvertently give a CCT, and then you'll see these findings of gyral enhancement. But this happens when the imaging is done beyond 48 hours in the subacute stage. Sometimes it can be confused with other pathologies like infection, neoplastic etiology, and whatnot. So it's better not to give a contrast. CT is avoided. Then we address the next topic, the CT angiography for a thrombus localization. The types of the CT imaging can be either single phase, multi-phase. For multi-phase, you generally look for the collaterals. This is the first study which from the aortic arch to the vertex in the single phase. In the multiple phase, we study from aortic arch to the vertex. The second phase is after a delay of 6 seconds, then this reverse turn from vertex to the aortic arch. Then third phase, we just cover this region, and that's all. So this is the first phase, the second phase, the third phase. You can see eventually how the collaterals are standing up in the third phase. So as a checklist, you have to remember the 4 steps. The first is to know the site and the length of the occlusion, that is a clot burden. The collaterals which are distal to the occlusion, whether there is a tandem lesion, especially in the carotid bifurcation region, and the vascular anatomy. It means that whether there is a tortuosity of the aortic arch, what type of aortic arch we are dealing with, and site and length, like whether it's a distal ICA, M1, M2, M3. So up to M2, I think things are amenable for endovascular therapy. In M3, the trials have not gone in favor of thrombectomy. Then we come to the posterior circulation. Again, commonly it involves the basilar. And here the time window is more than up to 24 hours, and the outcome can be pretty good. So this is an example of a middle cerebral artery tertiary infarction, and the cause is a thrombus, which is starting from the distal ICA, including the A1 and the M1. We call it a T occlusion, right? And these are the situations where I think aggressively intervention should be performed. So coming to the posterior circulation stroke, we have a PC infarct on the left side, and this is the MIP images. In the actual plane, we show that the beyond P1, the P2, the P3, and the P4, they are not filling at all. And that's why the infarction has happened in the distal territory. This is the sagittal little oblique shows that the P1, beyond P1 is occluded, and this is the right side, which is the normal side. Then this was the case which I showed when there was a thrombus in the basal artery. If you do a CT angiogram, you can clearly see the length and the extent of the thrombus in the top of the basal artery. Another example where there was a thrombus in the top of the basal artery, CT angiogram shows that the top and the P1 and the on the right and the left side both are showing the extent of the thrombus. And this is another example which shows that the M1 is occluded, and some other example which is an example of a MCA occlusion caused by the carotid atherosclerotic disease intracranial. So M1 totally occluded, not much collaterals, but if you take a second phase and the third phase, poorly visualized collaterals if you compare with the left side. So already the infarct has set in. Now coming to the clot burden, there have different scoring systems which have been used for a thrombus clot burden. Basically, if the thrombus burden is more, then the outcome is less favorable. If the thrombus burden is less, the outcome is pretty good. That's why this thrombus burden is being looked at. Now coming to the collateral assessment, there are various ways of knowing the collaterals. I've already highlighted that if you do a multi-phase study on a CT angiogram, then you can usually see the collaterals. Now this is a schematic which shows that the collaterals are not so good, and the resultant infarct is pretty big. But when the collaterals are good, the infarct, the size will be limited because the penumbra will be perfused by the collaterals. So these are the grading system proposed by various authors, especially the CAN. Then there is a Calgary group, which has grouped up to 6 grades. But the important is to know whether the collaterals are poor or very good, right? So if the collaterals are good, if you intervene, then the outcome is generally good. Coming to the tandem lesion means there is assessment of the common carotid. So if there is a thrombus here or the atherosclerotic plaque and there is a thrombus distally, this means that this is a tandem lesion. So here the strategy will be entirely different. You will first have to target the lesion in the proximal segment before you can get access to the thrombus exactly. So aortic arch status is extremely important. That's why when we do a arch study, the study starts from aortic arch, go to the circle of Willis. So you'll get to know whether the arch is bovine, what type of guiding catheter and the navigation system needs to be chosen before we can really embark on the intervention therapy. So this is the aortic arch, normal looking, right? And this type of aortic arch generally favorable for intervention because the time wasted is very less. These are the perfusion which needs to be studied, especially the cerebral blood volume, CBF, MTT, and time to peak enhancement. Perfusion, again, we have to look at the matching, whether it's a match or a mismatch. And in order to know the penumbra, these are some of the color-coded maps of CBF, CBV, mean transit time, and time to peak. And the yellow areas represents the penumbra and the red areas are the curves. So it's important how much volume needs to be preserved so that we can go ahead with the intervention part. So conventional MR imaging, I said that it is highly sensitive for detection of the early ischemic insult, and it is more accurate to rule out stroke mimics with MR than CT. And therefore, I think for posterior circulation, for wake-up stroke, to distinguish acute from chronic infarction, MR scores over the CT scan. So conventional sequences, generally we don't do any T1s and T2s. We rely heavily on flare, diffusion, EDC, SWI. And if we give contrast, 20 seconds, aortic arch to the circle of Willis can be acquired. And the total duration of this entire imaging lasts for less than 6 minutes. So we have designed a 6-minute stroke protocol in our setup. Now, let me come to the protocol that is being followed at my place. So this is a flare image, this is the diffusion, and this is the SWI. So these are 3 sequences. The 4th sequence is the EDC. So we always complete these 4 sequences, and based on the affordability, whether to acquire the contrast or there are contraindications for CT angiography, we go ahead and perform the MR angiography as well. So we do not rely on T1 and T2, we rely on diffusion because acute infarct will be bright on DW and it will be dark on ADC. SWI is a highly reliable sequence because it will show the intraarterial thrombus, which will be seen as a blooming, and it is much more sensitive or analogous to the hyperdense MCS sign, particularly picked up on the CT scan. The cortical vessel sign and the brush sign are better visualized with SWI. So example of the MCA territory infarction, especially the acute one on the left side, you can see the gyral swelling on T2 and blurring of the gray-white matter differentiation on the flare sequences. T1 just show a swelling and effacement of the sulci. So we don't spend much time, but if you look at the DWI, the entire territory looks hyper intense, and the EDC is dark, which means that this is a hyperacute infarct. Now the DWI may be positive after 30 minutes of onset of symptoms, but sometimes it can be positive in at minimum 5 minutes time, right? So this is a highly sensitive time, but it normalizes after 1 week of onset. So anything which is imaged after 7 to 9 days, you may not get any positive finding on diffusion and EDC. So this is one example which I showed earlier, and this is a parenchymal imaging which shows that the infarction is mesocerebral cerebral artery territory, which is bright on DWI and dark on EDC. So DWI, when it is negative in hyperacute stroke, what percentage it may be negative? Now, in 95% of the hyperacute stroke, diffusion restriction is positive. But when the DWI is negative, it is almost in 5% of the time. What are the causes? The causes may be location of the infarct in the brainstem, there is a small lacunar infarct, or the clot has lysed with recanalization and that signal alteration has disappeared. And sometimes when there's a less severe fluctuating hypoperfusion, in those situations, the DWI may be normal. Thus, I will say that a negative DWI does not exclude the diagnosis of stroke. In our setup, when the DWI is normal, we repeat this DWI after 24 hours. And in some of the cases, we have always picked up the changes. Now, coming to the SWI, it is a susceptibility weighted image. And this is because of the increase in the paramagnetic effect of deoxyhemoglobin plus increased hematocrits, which is secondary to the retraction and the fibrin formation. It is more sensitive than hyperdense MCS sign or flare hyperintense artery sign. and it is sensitive for all intracranial arterial occlusions. Successful recanalization, we have seen that the SWI findings have disappeared. Now, coming to the example, look at this image, right? All the veins, they will be little darker on the DWI because of the presence of deoxyribonucleic. However, in the region of the infarct, the veins stand out. They are prominent veins compared to the other side. And you can see sometimes the thrombus in the middle cerebral artery. This is a different case. We call it a blooming sign. And in a hypertensive patient, sometimes you can get micro bleeds which are darker on flesh sequences or the SWI. This is the example where there was a hypertensive MCS sign. And if you look at this MR angiography, there is a M1 occlusion. Now, coming to some of the examples, what happens? Like there is an infarct in the CT scan, the basal ganglia and the M2 segment. If you do an SWI, you can pick up the microhemorrhages in the subacute state, which is beyond 48 hours. The MCS susceptibility sign can see easily on the right side, and corresponding region, there's infarction, which is nicely picked up on DWI. Prominent vein signs is seen here, multiple territories. The veins are very, very prominent. Now, coming to the examples, like here, there is an MC hypertensive MCI. This is a watershed territory infarct, which is bright on DWI, dark on ADC, flare. There is a hyperintensity here. And there is a blooming, which is because of the hyperdense MCS sign or a thrombus in the middle cerebral artery with a corresponding occlusion of the distal MCA and the M1 segment. Now, coming to the DWI, right, you can do a lot of aspect scoring in a much better way if you use a DWI image than a CT scan. Now, coming to the concept of diffusion and flare mismatch. When the diffusion restriction is present, however, it is not apparent on flare. For example, this image. There is infarction as revealed by the DWI, as revealed by the ADSA, but the flare doesn't show many changes. And these changes are all old, nothing acute. So what does it mean? There is a flare diffusion mismatch. What is the significance of it? That the time of the insult is less than 4.5 hours. What is the implication? The patient is eligible for IV thrombolysis, and it's especially useful when we are dealing with a wake-up stroke or stroke of unknown onset origin. Now, compared to the another set of example, here the diffusion flare is matching exactly. So the MCA territory infarct seen on DWI, seen on ADC, exactly matching the flare. It means that the stroke has been beyond 4.5 hours and therefore is not eligible for IV thrombolysis. So that rules out thrombolysis by giving IV TPA. So coming to the DWI, SWI mismatch, this is another example of a 50-year-old patient. Look at this DWI. These are only hits, small hits seen on ADC. But if you focus on the SWI, there is a prominence of all these veins which are sluggish in flow, and that's why the deoxyhemoglobin is blooming on a S susceptibility weighted image. There was a delay in treatment, and after deterioration of the patient, the scan was repeated again. And now you can see exactly the area which were absorbed abnormal on the first SWI. Corresponding area shows complete infarction. So this is the importance of comparing your SWI with the DWI and the ADC. Now moving on, what is the fogging effect which is there on CT and T2? It is seen in subacute stroke beyond 7, 10 days, 12 days, 15 days. Flare, T2s may be normal. If you give contrast, the enhancement happens in the infarcted territory, and therefore they call it a fogging sign. The MR angiography has practically the same role as the CT angiography, generally done when there is a contraindication for a CT angiogram, and practically the advantage, disadvantages are same. So perfusion, diffusion, everything can be done by using the MR protocol. And we also have a diffusion and perfusion mismatch when the diffusion in fact is small and the perfusion is large. So coming to the comparison of CT versus MRs, CT-based protocol is the first line of investigation because it's widespread availability. The speed of acquisition is pretty fast. The study can be completed within less than 30 seconds. It is most cost effective. Disadvantages, that involves radiation, so it cannot be repeated many times and number of times, and it is relatively low sensitive for acute ischemic stroke, especially when we miss out the early signs of ischemia. MR-based protocol, it gives much more accurate assessment of the infarct curve by using a DWI. It is sensitive for acute ischemia. Then reduction of acute stroke onset in wake-up stroke is extremely important. And here the MR scores over the CT scan. The accurate diagnosis of stroke mimics is possible for MR, and there is no radiation. Limitations, not widely available. It has a longer acquisition time, and it is contraindicated in patients with cardiac pacemakers or cochlear implants. So conventional DSA is done when we want to intervene exactly to go in and remove the do a mechanical thrombectomy and remove the clot. So these are some of the examples which we have done in our place. You can show that the middle cerebral artery is totally absent from here. This is the PCOM and the PCM. This is the anterocerebral artery. You can also see the collaterals in the retrograde manner trying to perfuse the area which was supplied by the middle cerebral artery. So this is a dynamic, and therefore I think the collateral circulation, the status of the clot, the thrombus burden, the length of the clot, I think it's better picked up on the DSA and the vaso-CT or the dyna-CT that generally we perform. So coming to my last slides. So time is brain, as has been rightly said by Dr. Bindu Menon. In a typical acute ischemic stroke, every minute until reperfusion happens, the brain loses 1.9 million neurons, 14 billion synapses, 7.5 miles of myelinated fibers. Therefore, imaging has to be prompt to minimize door to needle time and to reduce the disability. Thus, the therapeutic time windows for various treatment strategies in acute stroke were formulated. We are moving increasingly from time-based to physiological-based paradigm, and it is more important to identify the salvageable tissue by doing the perfusion-based imaging, as has been highlighted by different trials like the diffuse and the dawn trial. Now we are marching into a different territory, like beyond 24 hours, can we intervene? And I think the Dawn Simple trial is going to address that issue. In India, we have done a safety and efficacy trial on patients who had a large vessel occlusion, who came within a therapeutic window, and where we tested the stent retriever, which is fortunately designed by our Indian engineers from IIT Mumbai and Hyderabad. It got patented elsewhere, but now we have successfully completed our study, and it is published in JNS. And based on the CDSO approval, now the device will be manufactured in India, and they are trying to manufacture it in Hyderabad. The impact will be to reduce the cost of the available devices, and it can set the protocol for future trials on many other things to come. So thank you very much. And I do hope that I have covered practically the relevant aspects of this stroke. And my talk has probably justified my presence here. So thank you once again, Dr. Arvind sir, Dr. Vinita Sharan, Dr. Bindu Menon, and everybody from IT and Dr. X.
Thank you very much, Professor Gaikwad, for taking us through the entire spectrum of imaging in stroke, right from CT to MRI, and highlighting the key points. Before I come to the questions from the attendees or the participants, there are a few, but many of them you have already answered during your talk. I just had one question to ask you, and it is not a professional radiologist question. My question is, if a patient has stroke, so how would the patient or the caregivers know which hospital to go to, which hospital has a 24/7 facility to diagnose and to intervene?
That's the most difficult question to answer. I think there should be a database information, and the city, I think, should be managed by a center where the dashboard shows that this kind of treatment is available in this. We have a comprehensive stroke center in the vicinity of the area where the stroke has happened, or the centers which are not yet endo ready, but they can admit the patient with getting a CT scan and giving IV thrombolysis. But suppose there is a large vessel occlusion, it requires another step of treatment like removing the clot, performing the mechanical thrombectomy. Then the tertiary care or the comprehensive stroke center, the patient should be referred there. So a lot of information is now available on different sites. I think the last time there was a National Stroke Summit where the ministry has taken a step forward and it's trying to involve the hospitals from the government sector as well as private sector, and they are trying to generate the awareness amongst the public, and not only about the imaging, but expanding the therapeutic paradigm into the more peripheral area like the tier 2 and tier 3 cities. So most of the comprehensive stroke centers, unfortunately, they are available in the tier 1 cities, especially the most urbanized.
Only their list needs to be publicized and should be available with all medical centers.
It is published already, but it is on the Ministry of Health website.
Okay. So there were a few questions. You've answered most of them actually, and that they were in the beginning of your talk. One was, can you elaborate on aspect scoring and its practical utility, which you already dealt with in detail. Another question was subtle radiological signs on a non-contrast CT. Should we as clinicians be careful not to miss in hyperacute stroke? I think you answered this. Do you want to add something to this question?
I think the early signs, I think we need to get training, basically how to identify them. So for anterior circulation, the findings needs to be located at the basal ganglionic region and by taking a section at the body of the lateral ventricle. So if you look at the middle cerebral artery, the cortical division, the M1, the M2, M3, M4, M5, M6, you can easily identify the stroke in this vicinity. But if you look at the basal ganglia, you should always compare with the normal side. So here comparison with the normal side, section by section, region by region is very, very important. And then should always look at the middle cerebral artery, whether there is a hyperdensity, and it should be asymmetrical on one side, not on both sides. That's one thing. For posterior circulation, I don't think CT scan is the appropriate thing. But if you focus on the basilar artery, the hyperdensity generally picked up. So I think these are the earliest signs, and I think we should really focus. And of course, I have already highlighted the importance of making window setting changes, the width level and sector level. So those are the things.
Yes. And also, how does imaging influence your decision making for mechanical thrombectomy in borderline or unclear cases?
If the CT shows a very large infarct, fully formed infarct, right? Even if the patient has come in the time window, generally, I'll be very reluctant to perform the mechanical thrombectomy if it is even tempting to look at the middle cerebral artery occlusion. In this situation, I generally go for the perfusion-based study. If there is a salvageable tissue, which is at least 30% more, then generally I go and intervene. But suppose if the infarct is on the left side, there is a sizable infarct, but some of the critical eloquent regions of the brain, like the speech area, the Broca's areas, the angular gyres, they are preserved. In that situation, my protocol varies, and I take little more risk because I will go ahead and remove the clot in order to protect these eloquent regions of the brain. So even if the aspect is low, in that situation, I think most literature, especially studies from the Buffalo, have recommended mechanical thrombectomy. So here, my strategy will be very different. And in posterior circulation, yes, even if we have crossed the time window, if the brain has not infarcted and there is a basilar artery occlusion, sometimes we do take intervention. So, and aspect scoring, yes, of course, I think we have already highlighted some examples, and the aspect scoring also relies heavily on the earlier science also.
And there was another question on the MRI protocols, which you had dedicatedly covered. So Before I hand over to Dr. Bindu Menon, I request her to please elaborate on her project, Neurology on Wheels. So, because it sounds very interesting, and then you can give your remarks or any interaction or concluding comments. Dr. Bindu.
Actually, can I just take 1 minute? Dr. Gaikwad, this camera seems to be off. Would you like to be on camera?
Yeah.
Yeah, okay. Okay, Dr. Menon, you may carry.
Neurology on Wheels, very interesting. I mean, is there a system that you can actually reach the stroke patient yourself on wheels?
No. Thank you for that question. And this is a flagship project of the neurology of the Dr. Bindu Menon Foundation, in which we follow the motto of we reach, we teach, we treat, where we go into the community, into the far away where there is it is a resource poor, also medically unequipped, and we make them aware. Rightly put in that your question also needs to be answered here, that where will the patient go when the patient has a stroke? So in our study, which we published in the Annals of Indian Academy, we found that most of the time the patient tend to recognize, the relatives tend to recognize that it is a stroke, but this hop, skip and jump from the doctor's outpatient clinic, then to the stroke ready hospital makes them makes them out of the time window. So we teach them that which are the stroke ready hospitals in the city of Nellore and about Nellore where they can really reach, and what are the symptoms of that. And then we screen the patients for a stroke and epilepsy and other neurological disorders, and divert the patient to the primary health center for the continuity of care. We also have an app, the Stroke Connect app, to again answer that question, and Dr. Chaturvedi, that I have this app for this from the foundation again, where the general public can download the app and keep it on their phone. It also gives them and informs them what are the warning symptoms of stroke. So when any of those symptoms comes, they have to just tick on those symptoms and then press the button submit. We get a call to the hospital, we get a mail, as also there is a call where they can call us. So when the patient reaches the hospital, we already have the demographic details of the patient, the medications that the patient is taking, and what are the symptoms. Like if the patient has got an eye deviation, we know that this could be an LVO. So probably the patient might need a thrombectomy procedure as well. So we know that how to triage the patient in these settings. Then thank you very much for this excellent talk, Dr. Gaikwad. Just one question, because of your wide experience, I just want to know, among all the classical CT scan signs, when we are talking about the hyperdense sign, the loss of insular ribbon, the obscuration, or the hypoattenuation, which one do you think is the most frequently overlooked in routine emergency reporting? And is there any practical approach you would give to the delegates, that you go from this way and just check 1, 2, 3, 4, so that you do not miss any of that?
Generally, I recommend people to look at the basal ganglia region. First, look at the symptoms of the patient, find out which territory is involved. So look, if you know the territory, suppose it's a right MCA, then look at the left MCA territory. And then region by region, compare it to the right side. First, begin with the caudate, go to the basal ganglia, go to the insula, go to the internal capsule. When these 4 regions are done, then go to the cortical region, compare section by section on the left side and the right side. First, go to the normal side, again go to the cortical side, which is affected. You will definitely identify the cortical effacement sign, the loss of gray matter differentiation signs, sulcal effacement sign. Those subtle findings are usually picked up if you focus first on the normal side and go to the abnormal side. And then at the convexity, you go to the level of the body of the lateral ventricle and look at the region, the M4, the M5, and M6. I think here people make mistakes sometimes because they don't compare with the normal side. If you compare with the normal side, then the possibility of missing out the lesion is minimized. And if nothing is obvious, right, then go to the CT angiogram. Sometimes we have picked up stroke and a very distal territory, especially the mevo territory, by just looking at the source images and the paucity of the blood vessels and comparing with the normal side. So this I think source images of the vascular phase is also equally important. And of course, when the CT is apparently normal, before you say normal, the patient continues to have a deficit. There is no harm in taking the patient to the MR, run a 6-minute protocol, so that at least subtyping and diagnosis of the stroke is established, because it will alter the management altogether. So in my setup, what happens basically, if the patient has come in the last 4.5 hours, if the stroke is visible, if the CT angiogram shows large vessel occlusion like MCA or distal ICA, we don't push the patient into the MR. Our DSA lab is just next to the CT room. So we leave the patient inside the angiogram, and then we prepare the patient for removing the mechanical extraction of the clot. Of course, we complete all the other formalities like informing the patient's attendant, taking the informed consent. Our neurologists are always around us, and they are always supporting us. So here, the protocol in AIMS is pretty set. Patient coming to the emergency straight away comes to the CT room of our department. So all clinical examination is done right in presence of the CT technician in our CT room. CT is done immediately. And as the CT shows evidence of stroke, the neurologist, if the patient is eligible for IV thrombolysis, will set in the IV line and push the drug in the CT room without taking the patient to the ICU. Once that is done, if the patient is also eligible for mechanical thrombectomy, then generally patient is pushed into the angio lab. We are always there because we get a call 10 minutes before the patient is shifted to the CT. So by the time we reach the angio suite, patient is already in the angio. So our protocol, we minimize the transport time from the emergency to the CT and from CT to the angio lab. Once mechanical thrombectomy is done, we again do a post-treatment CT scan to look for any hemorrhagic complication or complication related to the intervention before shifting the patient to the ICU. And then the neurologists take over in the ICU. That's the protocol that we have formed. Over the years, we are practicing this, and I do hope there will be further improvement in the protocol.
Thank you. Thank you very much for that explicit explanation of how the Center of Excellence at your place works. I think having said that, every stroke ready and comprehensive stroke center do make their own protocols, yes, depending upon their availability of the manpower, as also the availability of the advanced technology which we may have, and then maneuver our way towards it. If I'm permitted a last question, and that because we are hovering on CT, and we know that many of the centers have just CT, and that's when they need to get the patient into either a stroke ready or a comprehensive stroke ready center. So in your practice, when we know that all the ischemic signs are manifestations of cytotoxic edema, and yet the CT visibility in many patients are different. Some of them pick up so very fast. So what do you feel that determines this? Is it because it is primarily the infarct severity of that particular individual, or the collateral circulation, as you very rightly pointed out, or the CT technology in that various setting? You feel that the CT can be probably upgraded in their setting? That's what we are trying to get through this webinar. Or is it the observer's eye in general?
I think it may be both, but the first thing is the technology. If you don't have a good CT technology, the multi-detector CT scanners, then generally the other scanners, I think the conventional CT scanner, they are poor in resolution, and I will not blame the observer or the radiologist for missing out on those ones, because we also used to miss a lot. But over the years, with improvement in the technology, the advances, the rapid scanner, thin slice acquisition, less than 1 millimeter slice thickness, I think because of this advances in technology, I think the chances of missing out CT, saying CT normal, has significantly gone down. And also, if the CT even if it's normal, CT angiogram is the next in line. So it's not that patient is not going to the ward before CT angiogram is done. If CT angiogram doesn't show large vessel occlusion, it means that the patient is not eligible for mechanical thrombectomy. In fact, if eligible, IV thrombolysis may be sufficient in that setting. And the patient, if eligible, will be receiving IV thrombolysis right in the CT room. And if the clinician still wants to document whether the brain is infarcted or not, the patient goes to the MR, otherwise straight to the ICU. And the next day, then we subject the patient for a repeat scan. That's the protocol in our place. So partly it may be related to the technology, and partly because we are not very focused on detecting the early signs of ischemia on a CT scan. And our eye trays, I usually generally tend to pick up whatever area is bright. So therefore the MR, I think, has the highest sensitivity of detecting those infarcted zones. So I don't generally blame the radiologists. I will say that the proper technology should be available. At least bare minimum, you should have a 64 slice CT scanner in every place, right from tier 2, 1, 2, and 3 centers. I don't think 6 slice scanner or other scanners, multi-detector CT scanners, as of now, I think are of any value because they're pretty bad in quality, and we have come across those cases where it's hardly possible to detect. One more thing which I want to highlight here is that we have recently set up a facility of portable CT and portable MR, and it's meant for the bedside imaging, especially those patients who are critically ill. They are on inotropes, they are intubated, who cannot be shifted out of the environment of the ICU. Here we are providing them a bedside imaging, and the images are available on the console of the machine. So the clinician can take a decision right at the bedside. So this is what we have done now recently, and I think it's working pretty well now. Anything else, I'm ready to answer.
Thank you very much for that answer as well. And I suppose we are looking for more AI adoption, because I feel that it's no longer a luxury restricted to the Western nations, because these subtle features, if we have a cost-effective AI, which can be incorporated into the lower tier cities, so that the primary health center doctors really do not have to strive so hard, that would be more applicable in an Indian healthcare setting. Thank you very much for giving me this opportunity to chair such a wonderful session. Thank you, Dr. Shailesh, for such a great talk, and Dr. Arvind to introduce me, and Vinita and your whole team. Thank you so much.
So,
I think sorry, please go ahead.
I also wish to thank you for this honor, and it has been a great experience. And I'm glad to interact with Dr. Arvind, because we have not met for a pretty long time, because the last time we met was in Rishikesh for another CME. And nice interacting with Dr. Vinita and Dr. Bindu Menon for that excellent introduction, and moderating the session pretty well. So thank you all of you for giving me the opportunity. It's a great honor.
Thank you very much, Dr. Gaikwad, Dr. Bindu Menon, Dr. Vinita. I think Dr. Vinita probably want to close the meeting.
Yeah, I'll just take 2 minutes. So firstly, thank you, Dr. Gaikwad, for such an interesting and informative session. I'm sure all the physicians and radiologists who attended this session have gained a lot from your experience and knowledge. So they will be looking at their patients differently when they are suspecting stroke, and they would know how to proceed with such cases. And thank you, Dr. Menon, for adding value to the clinical aspect of this diagnosis. And Dr. Chaturvedi, thank you so much for moderating the session so well. So thank you to all of you. And then I would also like to thank the audience, because their presence and interaction and asking questions has really made it worthwhile to have the session. And I would like to thank DocPlexus, which is our digital outreach partner. They have been very kind and they are organizing the digital platform for us now. And last but not the least, I would like to thank our GAPIO technical team with special thanks to Ms. Ritu Khanna. She has been a great help in getting everything together. So thank you, everyone. Have a great evening. And this session has been recorded and would also be available on the YouTube channel of GAPIO. So anyone interested, or if you would like to introduce some friends who would want to see the session, they can see it at their own convenience. So thank you so much. Yeah.
Thank you, everyone. This is Ritu Khanna. And you can connect with me and I'll share the link with you so that you can see the session. Thank you so much for such informative session.
Thank you very much.
Thank you so much, ma'am. On behalf of DocPlexus, thanks to all our faculty members. Thank you.
Bye-bye.
Thank you, Dr. Flex. Thank you very much. Bye-bye.